Gina Rodriguez, and I'm the project manager for the Community Health Training Institute. We're happy to be with you this morning and wanted to welcome you again to the Quality Improvement webinar that's brought to you for free thanks to some generous funding through the Department of Public Health. And we wanted to give you some information about how this webinar is going to work. So if you can hear me, we would love for you to type into your question box, which you will see on your screen on your right side. This is what it looks like. So if you can hear us, just say, yes, we can hear you. As we get started, you are going to use this question box to type in any answers to questions that we're asking you, or if you're having questions about the presentation or how things are moving forward, please feel free, again, to type them in that question box. And we'd be happy to answer any and all of your questions. This is some more information about how we're going to work today. Please feel free to follow us on our social media at HRiA Institute on Twitter and use our hashtag MACoalitions. This webinar is going to be brought to you by Karen Arricchetti, and she's going to give you lots of information about herself, and we're going to get into it. Again, if you have any questions or if you're having any audio issues, please feel free to type them right into the question box. Thanks, Gina.
Good morning, everyone. I'm Karen Arricchetti, and I'm a senior research scientist at Health Resources in Action. I'm also an experienced quality improvement specialist, and I have experience implementing quality improvement initiatives for collaborations, including IHA-based breakthrough series collaboratives, and also working with multi-sector partnerships to use QI as a method for achieving population health outcomes. Before we get started, I just wanted to let you guys know we're going to be doing a poll. I'll ask our team to bring that up. So I'll just get started by reading this. Is your organization funded by the Mass Department of Public Health for any of these programs or initiatives? Please feel free to select all that apply. Mass in Motion, the Prevention and Wellness Trust, substance abuse, tobacco, or violence and injury prevention. We'll give that a couple seconds for you to respond. Great, the poll is now closed. Okay, so it looks like, wow, this is exciting. 2/3 of you had checked off substance abuse. I'm glad because some of the examples I'm going to use are related to that topic, and also the Mass in Motion folks, who I have a special spot in my heart for because I used to work on Mass in Motion. So thanks for being here. Great. So before we get started, I just wanted to share some basic information about our company, Health Resources in Action. We're a nonprofit organization based in Boston, and we have well over 50 years of experience promoting public health and biomedical research. Our vision is a world where social conditions and equitable resources foster healthy people and healthy communities, and we know that's a vision that many of you on this phone share with us. Our mission to achieve that vision is to help people live healthier lives and create healthy communities through prevention, health promotion, policy, and research. Today, we developed a couple of learning objectives that I hope are helpful to you in your work. By completing this webinar, we hope that you'll have a better understanding and be able to define quality improvement in the context of multi-sector initiatives. I often feel in public health we're always doing multi-sector work because that's sort of a defining characteristic of public health. So I very much am excited about this conversation and hope this helps you in your work. We'll also be able to name the elements of the Model for Improvement and its methodology, the PDSA cycle, or Plan, Do, Study, Act. We'll also be able to identify core concepts in quality improvement to organize a collaborative effort. I'll give you a bit of a roadmap of how to actually get that done, which I hope will help you organize any multi-sector work that you do with an improvement model. And then fourthly, describe how to use QI data to assess improvement over time. This is the metric piece, performance monitoring, part of QI. We'll go over that. And finally, we'll describe strategies for sustaining coalitions engaged in long-term QI efforts. So there's quite a lot of content to get through today, and I just wanted to share that. I prepared a lot of content. These slides will be available to you, and this will also be recorded. So if there's any section in particular you'd like to review more or get more information about, there's quite more content than I will actually talk about during this webinar. Also, I know this is a webinar, and you guys either have a cup of coffee, some water, or a snack, so hunker down. Feel free to get up, do the things you need to get done, and listen in. We all work that way, and I totally understand that. If you have questions, feel free to use the chat box, and Kelly and Gina will help me answer those questions. Finally, I just wanted to give you an overview of the timing should you need to get up and do other things in the course of your work today. These are kind of the topics we'll be going over. And we'll spend quite a bit of time on examples of each of these things so that you can see how it applies potentially to the work you're doing. And if at any time you'd like me to cover a different example that pertains to the content area you're working on, feel free to chat that content area in. So let's get started to the meat of this with what is quality improvement, and frankly, why should coalitions use it? Before I do that, I just want to say that I use the word coalition as a very broad catch-all term to really describe collaborative action. So if you refer to yourselves as a partnership or collaboration or initiative, there's many other ways to describe this, but I really just refer to collective action with organizations and individuals interested in improving health and health conditions. So quality improvement in the community health context is actually not that new. QI has been around since the 1950s, and it was first applied to improve or accelerate change in the manufacturing industry. Many of you may be familiar with the Toyota example of improving processes and the lean process. That's really where a lot of this got started. But improvement's not a new concept. Everyone's been improving their lives since the beginning of time, and the concepts are really applicable to how we live. In the 1990s, the Institute of Medicine and other institutions had issued many calls to action to improve quality. This included not just quality of care, but the systems of care that support healthier people, and also to improve the social conditions that enable or determine health outcomes. The healthcare payment system is also increasingly tied to quality through pay-for-performance or value-based purchasing strategies. This has not changed and in fact gotten a lot bigger over the last couple of decades. So it's something to consider when thinking about how to make improvements in population health. Funding and interest has really increased in improving healthcare quality and promoting community health over the last decade, particularly with the ACA, but also other efforts and hospitals being more interested in investing in the community health arena. And this also includes an enhanced measurement effort. Many federal agencies have actually been engaged in collecting and reporting publicly transparent data on quality, including AHRiA, HRiA, and others, CMS as well. Many training and resources for quality improvement in healthcare and public health have expanded over the last 3 decades. Most public health institutes now have a QI arm, or folks who are actively engaged in supporting public health departments in quality improvement efforts, particularly through FAB accreditation. So there are many, many resources out there, and it's actually can be quite daunting to figure out what should I use, because it's just an explosion of many different ideas. I'm going to pull some of those pieces together today. As I mentioned, there are other models of quality improvement models, such as the Lean method through Six Sigma. You may have heard of TQM, the Total Quality Management Model, or the FADE system, Focus, Analyze, Develop, Execute, and Evaluate model. But the model for improvement, or the PDSA method, is the one that has most widely been adapted to public health and healthcare issues, particularly through the leadership of IHI, the Institute for Healthcare Improvement, based in Cambridge, Massachusetts. And I'm going to talk a little bit about that today and the model for improvement and how it's used. But first, let's talk about defining quality improvement. I really like Batalden's definition of QI, and I'm going to share that with you with a little bit of amendments here or there. So QI is the combined and unceasing efforts of everyone, healthcare professionals, patients and their families, researchers, payers, planners, and educators, to make the changes that will lead to better patient outcomes, better system performance, and better professional development. Now, when I think of quality improvement, I think about the process and who benefits. Everyone is involved in quality improvement, not just folks who are on the ground and creating programs to improve population health, but everyone, including patients and their families. One of the cornerstones of quality improvement is involving the consumer and the consumer voice in quality improvement to make changes. There is a principle in QI of ensuring that all voices are heard, whatever part of the system they're in, which I find to be a really amazing part of public health, and it also underscores the work we do within the 3 core functions. So if everyone is involved, there are sort of 3 tenets to making that work. First of all, there has to be a population outcome of interest and a goal to get better outcomes. There needs to be training and professional development for the agents to enable those outcomes and a system to enable better performance. Solving today's public health challenges is, as always, and has been since the beginning of time, incredibly challenging and requires some complex solutions as well as collective action to solve. And most of the public health work we do involves teams, either at an organizational level, within organization, or at a community or even state or national level. There are 2 major kinds of collective solutions that we use, and one is the technical approach. This is the kind of example that occurs at an organizational level where we identify, test, and spread technical innovation or ideas across an organization. An example of this might be improving data systems in a medical practice to help understand outcomes for patients, for example, diabetic patients, and tracking their A1Cs and getting them to come in for follow-up care at 3 and 6 months. That's very isolated and highly technical. Adaptive solutions are the ones we most often think of in a multi-sector context. They occur at multiple levels in the socio-ecological model, including the individual level, peer, organizational, community level. And they require multi-sector engagement through partnerships. They are also incredibly difficult to sustain. And as we know, in public health, when we think of public health solutions, we are truly talking about adaptive solutions where action occurs at many different levels and is integrated over time. As all of us know on this call, there's a lot of pitfalls that we need to sort of think through when we organize coalitions to achieve a public health aim. I'm listing several of them here, but I want to call attention to a couple of them, and feel free to share what resonates with you in the chat box. The very big one for me is lack of clear and shared vision. Oftentimes when you pull multiple voices together in a room, it is incredibly difficult to come to consensus about what it is they want to achieve together. And that process needs to be done effectively. How can we do that effectively? What models are there to make that work? This is a pitfall that I think QI answers well. We'll talk about that. Another issue is getting stuck in never-ending planning. I'm skipping down because this one really, I think, happens all the time to us. How do we get out of planning? We talk and talk and talk about public health and what we want to do to improve, for example, obesity. How can we reduce obesity in our community or ensure that our seniors are active and do not have falls? There are so many challenges that we need to take on. Sometimes we keep talking about the how without actually getting to the how and doing it. How do we get out of that? So those are kind of the 2 that resonate with me. I'd be happy to hear from others if there are other challenges that you'd like me to address as I go. I think they'll come out as you hear some of the content. So let's get into the model for improvement and the PDSA method. For folks who have done a little QI, you may have heard of the model for improvement. It was developed by the Associates in Process Improvement and then popularized by the Institute for Healthcare Improvement in Cambridge as a tool to accelerate improvement. It is incredibly simple. It starts with answering 3 questions and then applying a method known as the PDSA or Plan, Do, Study, Act cycle to determine whether a change is actually an improvement. So let's tackle those 3 questions. The first is the aim. What are we trying to accomplish? You think in your coalition or your collaboration kind of what the goal is of what you're doing. This is an aim statement and the crux of the model for improvement. And it aims to answer these 3 things: for whom, how much, and by when. Sounds like a SMART statement for those of you who have to do those for your performance reviews. Everybody's got to have a SMART goal. An aim statement is a SMART goal. So here's an example of an aim to accomplish for a coalition. By December 2018, the Women's Health Coalition in Springfield County, which is a made-up example, will reduce the number of injuries among women aged 18 to 30 due to intimate partner violence by 30%. I just made this up, but it has all the elements of a great aim statement. For whom? Who are we doing this for? Women aged 18 to 30. How much? By 30%. And by when? December 2018. It also clearly identifies the actors and shows collective responsibility for this initiative by a coalition. The second question in the model for improvement is, how will we know that a change is an improvement? And this is measurement. This is the important part of knowing whether you're successful at the end of your work together. You're going to be collecting measures, collecting quantitative data so you can see if your changes result in improvement. An example could be the percentage of people with opioid addiction who find a bed in a treatment facility within 48 hours of ER admission. Now, that's a tall order for those people who are in the substance abuse community. I know there are many of you on the phone. But in order to know whether you're successful, you have to measure the stuff that matters, and finding out what those measures are collectively can be challenging, but it's incredibly important. The third question is, what changes can we make that will result in improvement? Changes are our ideas, our theory of change, and evidence-based strategies that we think will accelerate improvement toward the aim. Changes could be anything. It could be literature-based. It could be just a great hunch that you have. It could be a promising practice that emerges in a community. I often think of sometimes the work that was done in, I believe it is Gloucester, where the chief of police has this innovative program around bringing people in and making sure that they get treatment for addiction. That's an idea. Is it evidence-based at that time? No, it wasn't. But people thought, that's a great idea. I'm going to run with it. Let's move forward. So it doesn't have to be evidence-based, but it does have to be agreed upon as a strategy by your coalition. Other folks who do QI work look at the literature and bring out the best evidence they can in order to achieve an aim, and that could also be a way of doing it. Another example is opening a farmer's market in each town in your coalition to promote access to healthy food. For those of you working in Chenaz, where you have communities where you have large aims toward population health, one strategy to improve health and health access is to actually increase access to healthy food. This is a change concept and critical to identify as part of the model for improvement. So when you put all these questions together, you got the answers to these questions, then you get into doing it. And the model for improvement's methodology is the Plan, Do, Study, Act cycle. It brings about improvement by allowing you to work through a set of steps, knowing that change is a continual process. You don't just do one thing and just stop. You continuously learn from making changes. Some changes will work, other changes will not work, and some changes you just don't know. So this is the application of the scientific method. We're all familiar with when we learned how to test whether something was working or not working. We do this every day in our lives, trying to figure out what works for us. What time do we get up in the morning that helps us get to work? That's the scientific method. Also, the PDSA process starts small. Start with the smallest change that you can think of that you believe you can successfully implement, and then test that out and learn from it. That's what the PDSA cycle is all about. So I'm going to turn to our team here and do a quick poll to see what is your experience with the Plan, Do, Study, Act cycle. The response categories are, I have conducted several PDSA cycles before. I've conducted a few PDSA cycles. I have planned PDSA cycles but never executed them. And finally, I have never done a PDSA. Give you a couple moments to answer that poll. We're going to close the poll. Great. Okay. So it looks like, wow, okay, this is great. So some of you have conducted some PDSAs. It looks like about a third have done some PDSAs, or quite a few of them. And then some folks have gone through the planning process but never executed them. But the bulk of you have never done a PDSA, which is great, because we're going to go through how to do that. So this is my roadmap for planning a PDSA cycle. Some of you have done this and worked through the process. First, you make a plan. You make a prediction about what will happen, and then you determine how will you execute the change. If you pick a change concept, you have to determine, okay, who's going to do it, where will it take place, what exactly will be done down to the detailed level, and when will it happen, and for how long, if you want to add a little bit more to it. And then you have to collect some data, and you have to figure out how you're going to collect it. Then you go do it, carry out your plan and collect your data, and then you meet as a team and study it. What happened compared to your prediction, and why did it happen? What have you learned? In the act phase, you determine whether you should do another test. If so, how much bigger is that test going to be? So let me talk a little bit about the cycle of getting from a simple PDSA process to much bigger PDSAs. So we have a lot of data we collect when we do health promotion, and with a plan, do, study, act cycle, you start with an idea and you test it out on a small scale. But in order to know whether or not you should invest that at a system level, you have to keep doing PDSAs, getting bigger, testing in a larger population, taking bigger risks, and learning from your data. That's why I like this diagram, because it starts small and goes big. When the Patriots were a small team about 30 years ago and weren't doing that great, they made a lot of changes, small changes at first, to get a lot better, to become a better team now. And they started with a couple ideas of how to do that, the kinds of people they wanted to be on their team, the kind of plays they wanted to make, and they learned from their data, and that's why they're in the Super Bowl this weekend. Sorry, I had to get sports in there. It's that kind of weekend. And then to sustain that improvement, you have to continue holding your gains, sustaining your improvement, which is why the Patriots have been in the Super Bowl many times over the last decade. Here's an example PDSA, and let's work through this. This is actually an example from my own work. I do a lot of work in mental health and substance abuse, particularly with those who have severe persistent mental illness. That includes folks who have schizophrenia, major depression, and bipolar disorder. Imagine you are part of a mental health authority and you're in a partnership with 3 other authorities who are collaborating to improve integration of behavioral health care services with new primary care services on site. So this is what we refer to as co-located care. So these folks want to see if they can increase follow-up rates among this population, and they have traditionally a low show rate. These are folks who are at risk for not having sufficient housing and are at risk for a number of poor outcomes, including being in jail, having infections, being hospitalized, and being homeless. So they really want to get people to come back in, so their team got together with across the mental health authorities, and they sort of decided we're going to make follow-up calls directly through our receptionists to the patient's caregivers, because we can't seem to get people to come in when we call them, so we're going to call their family or whoever that person is of record. They predicted that behavioral health show rates at one of their mental health authorities will increase by 30%. So again, starting small in one location. They're going to test this out during the entire month of February at this single facility. So when they went to do this, the receptionist contacted 40 out of 70 caregivers to remind them of patient appointments in the upcoming month. This is important because you actually have to report what you've done. It may be the goal of doing 70 calls and only 40 were done, so you start to think about why was that. The result was that only 15% of patients showed up for their visits in February, which is actually an improvement overall, but 30% of patients with depression showed up for their appointments, and almost no one with schizophrenia did. So this is where it's important to know your data and to cut your data into pieces so you understand what's happening with the dynamics. The result was that the Adams Mental Health Authority, in this case, repeated the test among depressed patients at another facility to see if they got the same results. Same scale, same number of patients. And then they decided to meet again as a team to think about what they could do for their schizophrenic population, because simply the test didn't work. That's the magic of the PDSA. When we think about PDSAs in a multi-sector context, you can think about doing PDSAs just to fix one issue, to work on one issue. For example, implementing a quit line for tobacco cessation is just one arm of a multi-pronged initiative. But there are also other PDSAs you can do in other areas. So you can, as a collaboration, implement multiple PDSAs on different fronts. For example, you can work in the excise tax area, working with stakeholders to adopt different types of excise taxes to funnel money to substance abuse. Policy PDSAs are a little bit different. We're not going to cover how those work today, but it can be done. Similarly, promoting access to tobacco cessation tools, doing school-based work, and working with convenience stores, that might be your front line. But you need to be working in all these different areas in order to be able to really know if you can affect change at a population level. PDSAs are small, but they're not meant to be singular. So putting many into practice will help you get where you need to go faster. I'm just going to give you a quick example of how to do a multi-sector PDSA in collaboration. I'm just going to briefly gloss over this. You'll have this in your slides, but imagine that you are a coalition trying to improve primary care for those who are uninsured living in a rural area, and that you're part of a community health center and transportation system. You could do a PDSA where you could give out transportation vouchers to, say, 10 people to get them to come back for their lab work in a month. This is something that happens a lot, particularly with diabetics, getting them to come back for an A1C or to do labs for other things. You could work with your network of transportation partners and then meet as a team and figure out who used the vouchers, why did they use their vouchers, and then look at the results. In this example, you'll see that your prediction of half of the patients using the voucher wasn't actually what happened. When tests were done, only one patient used a voucher, 3 returned but didn't use the vouchers, and the rest didn't return at all. So as you think about this, thinking about what the next step is, think about the questions you would ask your partners. Well, what's happening here? This is the magic of the PDSA within a multi-sector context. I'm going to pause here and ask if there are any questions. And as we go, feel free to chat them into the box and my team will let me know. I'm just going to pause for a few seconds. I'm very good at asking myself questions too, but I want to make the most of your time as well. Okay, so we'll move on. So I'd like to give you a bit of a recipe book for how to organize a coalition using a QI approach. There is no one-size-fits-all approach to this, but there is sort of a method to the madness. These are the steps that I would say are essential in organizing a collaboration using a QI approach. And first is that your coalition is reasonably organized and can pick a topic. And sometimes you're brought together because there's a call for funding and you get an RFP issued by a federal agency that says we want to improve X. For example, you want to improve physical activity among school children, and so you bring together partners from the Department of Secondary, and I'm going to forget what DESE's abbreviation stands for. Apologies. Sorry if any of you are on the phone. DPH, you might want to bring in members from Boston Public Schools or providers, members of the community, and you sort of decide you're going to work on physical activity. But you don't really know what you're going to do. You still need to come together around a topic, and usually that's done for you or something that you've decided. Second, you convene a team, and then you define your aim for the partnership. Much like the model for improvement steps, there's really no rocket science to this. We follow the method of the model for improvement. Then you have to select how you're going to make changes. This can be the most complicated part because everybody has their idea of what the best way to do something is. That is the magic, and where the magic happens, deciding how you're going to handle a problem. And then you determine your measurement strategy and test those changes using the PDSA cycle and study the results to get bigger and bigger with your changes. As you refine your tests and implement your successful changes, you go to scale at the very end. That's the most exciting part of the project, and that's when you see the big needle move. We're always looking at the small needle of little changes that happen over time, but in public health we want to see that big needle move. And when you get to the end of the cycle, it's incredibly satisfying. That's where you want to be. So in picking a topic, you want to make sure that you look at baseline data, look at the literature, look at community health data. You may have some community health assessments that have been done in the community. You may want to look at that and to look at the direction it's going. Who's affected by it? If you're going to be looking at, for example, falls among seniors, who's it happening to? What communities are those happening in? Are there some markers to tell us who's most affected? Then you organize your coalition to select priorities. What's feasible for you to achieve and what matters the most? Then you pick multiple topics if you want to change multi-pronged problems. For example, if you're focused on healthy living, that's pretty broad. Getting focused and determining what your priorities are, whether it's increasing physical activity or ensuring that people have access to food or reducing food deserts, you need to figure out what it is you really want to do. Again, this goes to strategy. Second, you want to convene a team. In public health, we never do anything in a vacuum or by ourselves. Everything is about the team and working together. A QI team carries out the work of implementation, not just the ideas. These aren't just the strategy people. These are the people on the ground from the bottom to the top. This includes sponsors, but also content experts, people who know this field and know how to fix the problems that you're working on. You'll need project managers and technical experts who can go out into the field and do the work. And finally, but most importantly, you will need consumers to inform your work. And this could be patients and families, but also equally important is providers. If you're trying to change access to care, you want providers at the table to tell you what their perspective is because they are part of the equation. These teams are diverse and task-oriented. They are concerned with doing the work and moving it forward because QI is about accelerating improvement and change. If you sit in a room and you're doing lots of talking, as I mentioned before, that's great, but you need to get out of talking mode and into action mode. QI teams are concerned about doing that. Coalitions are also made up of several QI teams. You could consider a work group structure where you have sub-teams working on different issues. And don't forget, again, if I haven't said this enough, to include patients and families in your QI teams. I'm going to stop for a moment because I know that we have had some questions. Gina, would you let me know if there's anything I can answer?
Yes. So there's a couple of questions in reference to what you've been talking about. So you are mentioning sort of partners and working together and moving into the implementation.
Yep.
So what stage do you recommend that people bring in their partners? Should they be involved in the planning process from the beginning or when they're needed in the process? Do you have any recommendations?
It depends. I think sometimes when partners are brought in the beginning, sometimes you can have partners who are your core partners who are really engaged and have a stake in the work you're doing. Selecting partners, which is itself its own kind of topic, is really important at the beginning because if you bring someone else into the conversation when you've already made some key decisions like your aim statement, there can be disagreements down the road that could potentially threaten the success of your project. However, if you're finding out from your testing and your QI work that the strategies you had in the beginning aren't working and you need a different partner, you may need to do that in midstream. There are effective ways of doing that. I'd be happy to discuss offline about how to do that. But that can be necessary, and it's important to be flexible in bringing in partners when you need them. It's the great thing about QI is that it's a very flexible model and allows for engagement of multiple partners at different times. Are there any other questions?
Yes, we have one more question. In terms of quality improvement efforts, what's a feasible timeline for the planning, implementing, and evaluating? Is it specific to each project or?
Sure. Quality improvement is designed to be quick turnaround, and the typical engagement ranges between 12 and 24 months. However, they can be shorter. I've done projects that have been 3 to 6 months where it was more of a technical solution. Remember going back to organizational work where you're trying to change something within an organization, but there might be many stakeholders involved. I've also worked in collaboratives that are multi-year where you bring in folks to work on problems in phases. For example, working on a capacity issue first, then moving into moderate changes in practice, and then finally looking at cultural changes in the third year. So there's many different timelines you can use, but it goes back to what is your aim statement hoping to accomplish, and being realistic about what you can achieve with the funding you have, with the goodwill that you have and the capital you have within the community. Another key thing to consider is what do you have control over in your work. Can you control the policy environment? Probably not. What are the things you can't change about the system? And that will help you also determine how long it will take you to actually engage in a QI effort. Any other questions? That's it. Awesome. Well, we'll keep going. If you have questions as you go, please feel free to chat them in. I'm just going to keep on going. So the third step in my recipe book for developing a QI coalition is to define a data-driven aim of multi-sector partnerships. This is one of my favorite cartoons. Why are we doing this? Revising your aim statement can be something one does at a partnership level, especially when things aren't working out the way you thought. It's important to set at the very beginning a data-driven aim so that you know where you're going back to that model for improvement question about what are you trying to accomplish, and doing it using a SMART goal format. In setting that vision, it has to be clear and focused on a mission that you can achieve with measurable goals for your coalition. This needs to be owned by all partners and informed by community and contextual issues. If there's a member of your team or coalition who doesn't kind of buy into this, you're going to be setting yourself up for long-term challenges. And that could also lead to partners either not being engaged or being apathetic to your work, or actually sabotaging your work. And you don't want to be in that space. Beware of broad agendas and focus your partnership by establishing goals and infrastructure to support those goals. So one tip I have for you is that prioritization exercises can be great sort of effort for everyone to get their hands on data so that you can focus your efforts together. When everybody's head is in the game, you do a lot better in terms of communicating what it is you want to do collectively. Use the tools of QI. The aim statement, while a written and measurable description of your coalition's desired improvement, is meant to be something that you all buy into, but it can help to write it down and to make sure that you all adopt it. If you have a formal coalition that meets with a board structure, it's important to approve that, to make sure it has adequate vetting, that people have time to review and comment, and for changes to be made. Multi-sector aim statements are a little different than an aim statement which might be, well, I'll give you an example of one of my own. By the end of this year, I would like to lose 20 pounds by cutting my calories and exercising more. That's an aim statement at an individual level. When we look at the multi-sector level, we want to make sure that it's as comprehensive enough but focused enough so we can achieve it. So this is an old one that I pulled because it says by April 2017, so probably not relevant and probably would need more time. But again, by a certain date, a substance abuse coalition will reduce the number of deaths due to opioid overdoses by half across the 25 communities it serves. I love this aim statement because it's ambitious and it really sticks its neck out over what it wants to accomplish. A lot of times aim statements are a little too afraid to commit. I hate to personify an aim statement. I'm going to do it. It's quite difficult when you're in a coalition to take a bold step forward, but sometimes this is where you need to do it. And so don't be afraid to kind of push the envelope of what you think you can achieve. It's better to set an expectation that's a little bit of a reach than something that is not a reach at all or low-hanging fruit, or that is not reachable at all. Take a stretch. This aim statement is great because it actually identifies how they're going to do this. And this includes many different strategies, from policy and advocacy to training law enforcement to doing Narcan overdose protocol training, and to do awareness work. It's got all the features of public health. Another example I won't go over, this is a school-based one on dental health and reducing school absenteeism. So there's many different ways of doing this. I'm just going to pause one more time, see if there are any other questions. Do you have any other questions?
I mean, I have a question that I would love, and we'll give a chance for people to type in the box as,
Sure.
as we chat.
Okay.
But I know that you mentioned sort of being bold, and that one of the struggles is that oftentimes these groups can get into the planning and talking and talking. You mentioned that at the beginning of the webinar.
Yeah.
And so is there any, in terms of decision making and the choice to move forward and just go for it, do you have any recommendations in terms of how to establish a solid sort of like decision making process? Is it consensus? Is it people just being okay with moving forward? What works and what doesn't when you're thinking about these multi-sector partnerships?
That's a great question. Setting up a deliberate process to getting to that vision is incredibly important. So I mentioned having a board structure and doing work to define a process, a transparent process where you can come together and actually work together collaboratively on an aim, where there's debate, where there's written statements that are then vetted, revised, and then approved. That's critical. I think the other piece to making sure that you can set a bold enough agenda is, again, going back to data and saying, where are we now? I've been involved in many different public health improvement projects, not just in my work in QI and in research, but as someone on the front line trying to affect change in the programmatic space. You want to be able to say, here's the literature and here's where we can go. But oftentimes we grab onto low-hanging fruit because we have funding, or we might lose funding, so we're worried that we won't go. Aim statements themselves aren't going to yell at you and say, hey, you didn't achieve me, but you will not be happy if you get to the point where I've just worked so hard on this and but we just didn't aim high enough. We could have done so much more. And oftentimes your funders will set these expectations for you, so there's kind of a murky space. But if you have the flexibility to define an aim statement with your partners, figure out what's feasible. Asking them to sort of say, what's your pie in the sky? Now, if you had to take the pie and put it down on a shelf that you could barely reach, what would that be? And have them define the levels of where you want to go. I think that helps have a conversation because it gets everyone excited about what's possible instead of just reaching for things that they think you might actually be able to execute. I also like having a short and long-term vision. If you have an opportunity to do a logic model for a program that you've done, in QI you can do the same thing. We'll talk about what that is. There's a model for it I'll be sharing. But you can look at each goal and think, I'll start with low-hanging fruit, but then I'm going to get here. An aim statement should be visionary. It should be big, bold, and not apologize for anything. But you can take it back a step and do sub-goals and sub-aim statements that are more achievable, breaking it down and making it more digestible for stakeholders. So they're just some of the initial thoughts I have, but that's a really good question. And I think a lot of QI experts work on this all the time, is how to set that appropriately and making sure everyone's on board. If you've got somebody in your collaboration who's just sort of, I don't want to do this because I know that I can't show results, and showing results is really important, then that's also valid. And sometimes you have to start there, which is great because QI is about starting small. So you can start small with your aim statement. It's just not something I would recommend. I'm a big person to go big or go home with your work, because in public health, if you give an inch, they'll take it, whoever they is. And that could be barriers to adopting lifestyle change. It could be funders, it could be policy. You had enough people and entities trying to prevent you from improving health. Go big for the patients and the consumers. Go big for them. All right. So number 4, select the changes your coalition will make. This is the fun part. I like to suggest folks put a work group together with aims for each work group and brainstorm change strategies. Oftentimes you'll engage experts in this and have an expert meeting to develop strategies based on any data you have. So if you want to, for example, I hate to go back to obesity, but it's something we all work on, where you want to kind of move the needle on childhood obesity and you want to engage schools, you might hold an expert meeting with people who are administrators, superintendents, parents, members of the community who are potentially involved in the prongs of adopting healthy living communities, and then have them develop a roadmap or recipe book for how you could improve healthy living and also to reduce obesity among children in that community. One of the levers of doing this or way to organize is called a change package. It literally is a recipe book with this is the how-to guide for how to do this work. And it's just a list of evidence-based or ideas or hunches that are organized by driver. So I remember I mentioned earlier that you can change, you can set an aim statement for your own individual goal. And this is mine, healthy me in 1 year. And again, I set an ambitious aim that I was going to be healthy in 1 year. And I know this is the magic of webinars, but I've lost 86 pounds in 6 months. So this is a real driver diagram, and I'm going to do this. It's part of my world. But I had to kind of think when I was losing weight, how the heck was I going to reduce my body weight? That was my main outcome measure. So what drives that? For me, it was calories in and calories out like everybody else, but there were also some other drivers. If I could do this diagram again, I'd add a third driver that says psychology. How do I keep my mental health in a good place? Actually, I'm really going to do that with the slides the next time I do this. Then I think about what drives all those primary drivers. Well, for calories, it's how much I take in total, whether I eat low-fat foods or whether I have soda. That's a big one for me, and coffee with lots of yummy things in it. So how do I move that? But see it how on that top side it shows me that level of the system that drives my calories in that will allow me to reduce my weight. Similarly with calories out, that's about exercise, about measuring steps and working out and taking the stairs. Note that your secondary drivers are contextualized. For me, these are the 3 things I think will work for me, but they may not work for somebody else. So it's important your driver diagram as an organizational tool maps to what you're doing. How do you do this on a multi-sector level? So this is an example about the healthier weight piece that I mentioned before. And instead of looking at me, healthy Karen, I'm looking at decreasing the percentage of adults and children who are obese. Now I know the CDC collects this information at a national level. There's a lag to it, but we have state and local community data. Lots of ways to measure that. But the multi-sector aim is to achieve a healthier weight in the community. That is a go big or go home statement, because you're sort of saying we want people to have a healthier weight. That's your goal. And so by saying that and not saying we want people to start losing weight or we want to see a 0.5 decrease in this population here, this reaches everybody. It says from a health equity perspective, everybody's involved in this. The drivers are threefold, and I added coordination via a multi-sector partnership at the top because you are working in a partnership to achieve healthy weight. The secondary drivers of that are the right people at the table, the right resources, the vision for the partnership. Do you have effective leadership at the levels that you need it, and an organizational structure? And then when we look at the lower level about promoting healthy eating and promoting physical activity, then we look at the change strategies. On the right, under secondary drivers over healthy eating, notice I mentioned farmers markets, community gardens. Imagine sitting in your coalition that you have a conversation about the change strategies that you think will work. This community has selected these 4 drivers to work on because the context that they have decided makes sense for these drivers is mapped out here. So it's similar with physical activity. It's all about selecting the right strategies for your community. So I'm going to take another pause because I know there's another question and I'm going to answer that.
Sure. So this is related to the driver diagram.
Oh, good. I'm going back.
Our driver diagram templates resources publicly available for my coalition to use as a framework.
So they will be through me. Please contact us. My email's at the end of this presentation. I'd be happy to give you these slides in the current PowerPoint form. I made these because I've always looked for this, and you find a PDF that you can't even alter, and I hate that. So I will give this to you. However, one thing I do is I Google and I put in driver diagram and I click images, and you can find tons of examples of these. This is only one way to organize this, and much like the program logic model, this is kind of a great way of looking at it. So I'm happy to share this with you. I don't know that anybody else has one that you can edit, but this is definitely one that I work on. The other way that I envision this is that I sometimes use the review or commenting feature in PowerPoint to then tag each box with how I'm going to measure that. So you layer it on top, and it helps you kind of map out, okay, in order to know that my partnership is working, I'm going to measure X, Y, and Z. And that puts both the two questions, actually all three of the model for improvement questions in one place. So happy to share that with you. Thank you for asking that question. Well, speaking of measurement, your measurement should be tied to the changes you are making. So the next key ingredient to this process is actually selecting a strategy for measuring. You need to be able to measure your outcome as tied to the aim. If you're trying to reduce weight in a community, or you're trying to reduce the number of deaths occurring to opioids, then that's your aim, and you need to measure that. So folks on the phone working in substance abuse, you may want to measure something as big as mortality. But you also might want to just measure something that's more process-oriented or health services-oriented. You know, the number of people identified in an ER. You're trying to find people through the SBIRC system, screening people for substance abuse and intervention, then you may want to make that your aim by identifying more people through that system. That could be your outcome, but it's still very process-oriented. Then you want to sort of, again, tag each driver, primary and secondary, and figure out, are you making progress? Again, going and saying, how will I know that this driver has been put in place and how it's going? The third kind of measurement, which I won't talk too much about, is called the balancing or structural measure. And this is contextual. So essentially, this is something you might measure to look at the success or failure of the changes that you are making. There are many different examples of balancing measures, but you, for example, might want to, this is where you measure things that might sabotage your work. For example, anything that has to do with policy, in measuring something related to policy. I wouldn't worry too much about these measures, but if you do want to sort of measure things in the environment that potentially could affect your success, this is a great way to do it. Finally, use your coalition to develop your strategy and use these categories. Keep it very simple. I recommend you do not use any more than 6 to 7 measures. And that doesn't sound like a lot, but it is. It takes a huge amount of effort to measure anything. And so for your PDSAs, you might measure some smaller measures, but you need big ones to sort of see, are we making progress across all of our work? So keep it simple. This is hard to do. I once worked in a collaboration where they started with 45 measures and ended with 20. It took 2 years to get to that point. I don't want that to be any of you on the phone, and it shouldn't be. Because measurement's important, but it doesn't mean, again, that you should be stuck in planning. Get out of planning as soon as possible. Here's an example strategy, outcome measures around bullying. So I have written many papers on bullying. This is what I did my dissertation on. Percentage of children who report being bullied is one of the main outcome measures that you might measure if you want to know about bullying in a community. You may also want to measure the percentage of teachers who observe bullying in the classroom. These could be very important to your aim statement of reducing bullying in a community or region. But you may also want to measure the process. For example, the percentage of teachers who implement anti-bullying procedures. You might be able to measure that by direct observation or survey. A balancing measure in this case is a survey of families about student perceptions of bullying in school. Is there any outside consequences to the work that you're doing? Does this negatively impact or positively impact families and their perception of bullying in schools? That just sort of gives you a temperature of the system. It's not the system itself, it's the temperature of everything around it affecting the system you're trying to affect change in. The sixth step out of my process, my recommended process, is to actually go out and test changes and study the results. Remember, QI is about learning and failing and learning again. Develop teams in your coalition to test ideas and strategies that are represented in your driver diagram. Stay within your roadmap. I'm usually a person who says draw outside the lines, but in this case, when you first start, draw inside the lines, but just draw big and maybe paint and use different colors. Institute regular team meetings and reporting to the larger coalition. If you have a work group structure, your work groups can meet regularly, review tests, and report the results to the larger coalition with recommendations about what to do next. Meeting with people might seem like a lot of time, but these meetings are working meetings where you actively go through the study phase of the PDSA, look at data, react to data, and make some conclusions about what you need to do next. When you go through this step in particular, you want to emphasize shared learning, not judgment. This is so hard to do because when you do early work in QI, you can experience quite a few failures because you're testing things out that haven't been tested before. The context may also shift while you're testing. So I look at failure as an opportunity for improvement. QI is all about failure and looking for areas of growth and positivity. Learning is incredibly important as a cultural value in coalitions. If you can institute that in the very beginning of your work and practice learning as a community, you will be much more successful and able to sustain that work going forward. Take on strategies that you can implement and be very targeted about the strategies. Don't take on the world when you first get started. Start small and again, roll up the hill. Think of that boulder that you're going to roll up the hill, but as you do that, more and more people are going to help you push the boulder up, so the boulder is now small compared to the number of people that you've pushed that up the hill. I wish I had a graphic of that, but I'm not very good at graphic design. And finally, refine your tests and implement successful changes to scale. Results of your PDSAs should be always reviewed by the coalition and then refined in a team manner. The most effective and promising strategies should be scaled upward, and others should be left behind. Not all strategies can be tested in a PDSA, and again, this is usually around policy changes. Instead, the strategies in advocacy are typically around how to work with people who have control over policy and the context in which those exist. There actually could be a lot of work done in policy using QI, but policies have to have some level of control. The system that you work in has to be a system that your coalition has access to and can control. Do not take on something that you reasonably can't actually change. For example, don't pick regulation if nobody on your team is a regulator or a policymaker. However, it might be something that you want to change over time, and the advocacy piece of that could be your strategy rather than the actual change itself. That sounds like another webinar, Gina. We should do that. With scale comes larger coordination needs. The bigger you are, the more support you're going to need over time. This is tough because, you know, I've been in public health now for several decades, and I always need more help doing the work I do. Sometimes we wear multiple hats, and we're surrounded by many cooks in the kitchen and not enough sous chefs and not enough people who chop vegetables. It's important to ensure that you have the infrastructure to coordinate change and to have a communication strategy that supports that structure. Sometimes we get too big to fail. Too many people, too many partners, and not enough glue in between. So it's important to plan for that and think about at the end of your work that you're going to scale up. So I'm going to pause again and see if there are any questions. Again, feel free to use the chat box. We have about a half hour left, and I've got a little bit more content, but we'll have more time at the end to answer any other questions and for me to share other examples with you all. Okay, well, we're going to keep going. If there are any questions, feel free to chat them in. Thank you for sticking around for a whole hour. That's impressive. I hope you guys are getting your lunch soon and continue drinking coffee and whatnot. All right, so we're going to talk about data. Sorry, I went too far. Using quality improvement data is one of the essential disciplines of QI strategy. And as I mentioned before, QI data is a foundational activity that allows you to learn from the ground up. I love this cartoon because it talks about the foundation of using data and measurement for building improvement. And all those little building blocks actually say the word data on them. I also like to think of data as being not just the data itself, but the interpretation and the contextualization of that to your work. If we've got a ton of data, great, but it has to mean something. And when you look at it with many different eyes and different perspectives, you get a much better sense of what your foundation is. So that's a key critical step in getting started with QI. QI data is different than research data. Now, I'm a researcher by training. I literally have the title Senior Research Scientist. But in doing QI over my career, I realized that sometimes you don't need to collect everybody. You don't need to do a census every single time you want to answer questions. Sometimes you just need to track the system of what you're doing. What do I mean by that? QI data represents the scope of what are you doing right now, not necessarily the whole system. If you're working within one ward of one hospital, you measure the ward, not the whole hospital, because your work and your action is in that ward. I've worked on a lot of breastfeeding projects where we're working on skin-to-skin implementation and the baby-friendly work. And you might be testing that out in one suite of your hospital, but not in others. You measure the system you're working in. It's not research data. You're not collecting it for the purpose of publishing a paper, although you might, but generally it's data that's de-identified. You're not collecting anybody's name. And the denominator is going to be small in the beginning and different across different tests. For example, you might start with a test with 2 patients, so your denominator is 2. And how about one has one result and the other has another? Well, technically that's 50%. With the denominator samples only 2. In research, we would say that's a small sample. In QI, we would say that's the right sample. You start with baseline data and you collect baseline data to set a foundation, and that could be really, really tiny and in different contexts. It should be part of your routine to collect data where you're doing work. And remember, qualitative data matters. In research, we do a lot of qualitative work. In QI, qualitative data is contextual and it drives your work. This is where the voice of the consumer and the provider and family comes in. I used to work on a QI team where we were trying to improve screening of newborn hearing tests, and for folks who had a negative result and getting them to go to audiologists. We had a deaf parent and a deaf child as part of our team, and whenever we made a change, we would ask them, what should we do? Should we listen to the voices of the people in the room? Should we just look at the numbers? What should we do? And I will never forget that that family signed to each other what they thought they should do, and then they told us. And they actually did speak to us. They chose to speak at that point. And I remember being incredibly moved by the fact that I just witnessed exactly what we should be doing, which is qualitative work and listening, literally listening, looking at hands in order to understand what was happening. This is an incredibly powerful tool in QI, not just in research. You're not just looking for quotes. You're looking for action. You're looking at observational data. Go into the ward of the hospital and observe. Talk to patients. Ask them questions. And in public health, this could be going to a playground and interviewing a parent sitting on a bench watching their kid play. Utilize your coalition to collect those stories about your QI efforts. You may even want to document them through video and use social media to do that. Don't be afraid to do that work. This is just a quick list of example measures. I'm not going to go through them all, but there are measures that you collect that are process and outcome. Remember, your measures should tell a story and should be relevant. I like the ones at the very end here where we talk about partner attendance at coalition meetings and number of new partner members at a coalition. I really like this one because I once went to a coalition where we had a problem with people not being engaged. So we started showing a slide at the beginning of who was engaged and who wasn't. I'm not suggesting that you do that, but sometimes you need to have your own data and your own QI process at your coalition to sort of say, here's where we are. And one of our goals is for people to be engaged. This is our level of engagement. This is what we need to do to improve it. Selecting your measures sometimes can be temperature taking of your own work. The run chart is a great tool and one of the best tools for QI, examining QI data. This is one that I developed in a project where we were looking at access to psychiatrists. So if for any of you who work in health services and particularly in looking at medically underserved areas, you know that there are some states where there's only 2 or 3 psychiatrists in a single area, or none at all. And so we were looking at the percent of patients who wait for more than 6 months to just to get a psychiatry appointment. And this was among people who were underinsured or uninsured. This is years ago. And so we were doing an intervention and we were tracking data. We look at June when we started, around 80% had to wait this length of time. And we've created a run chart of this work where the green line, I apologize for those who are colorblind, but it's the one where it spikes up at the top. That was our tracker for that period of time, and we just ran through June and went straight through for about 14 months. We also looked at our goal, which was 30%. That was tied to our aim statement, and the median. The median is a great tool to figure out if you're making success or changes. And so we looked at what we were doing here, and then something happened in February, and we were like, what the heck is that? I have no idea why it's spiked up that way. And so the run tool just sort of allows you to see trends at a high level. There's also a science to looking at these charts. I'm going to show you a tool we use in run charts. It's annotation. This is another, this is a Narcan training run chart that I did in a project where we train law enforcement officers to do overdose prevention. Well, at one point there was a plateau in our work, and again you can see the note. We were looking at a process measure, the number of police trained. There was a funding delay in training for the 2 towns out of the 4 that we were in, and so we flattened out and stopped training. But we only had trained about 21 people at that time. And then we, of course, started to move again. It's important to annotate your charts. Oftentimes we don't do this because Excel doesn't allow us to, but you can use the commenting feature in Excel to create these comments, or you can use the text box. It's very critical to see whether or not you're meeting your goals. So how do you know you're improving? This slide is the one that drives me crazy because it's just weird. There are rules, apparently, and about figuring out whether you're improving. And so I put them up here for you. There's an entire course that you can take on how to actually do this. But there is a scientific strategy for interpreting run charts by looking at these 4 rules. For example, Rule 1 is a shift, which means that you have 6 or more points that are above your median line. The blue line is your median line. Again, the median is a tool used in QI. So you don't need fancy statistics, but you do need to be able to look at where your points are above the line. If you see a shift from, in the case of Rule 1, from under the 6 points under the line to 6 points over the line, you know you're improving, and there is a scientific basis for knowing that change has happened. Similarly, for Rule 2, a trend, you see 5 or more points going down or up or in any different direction that occurs at any point where the median line is transversed. So most people, when I share this information, it's like, okay, I'm going to not listen to this because it's over my head. It took me a long time to figure this out. But I like this slide, and I hope that if you do get into this work, just print this out because it actually shows you what the rules are and good examples of what they are. I stole these from a friend of mine who is an improvement advisor, and I use it all the time. My favorite rule is Rule 4, the astronomical data points. If we go back to this slide where we looked at psychiatry, there really wasn't any explanation as to why we had this blip in the screen. We didn't annotate it. Nobody kind of knows what the qualitative story was. But that's an astronomical data point. And so when we look at improvement, something was shaken up there. We lost an opportunity to figure out what that was by not tracking it properly. So this is just a little bit of a cheat sheet for you if you get into this work. This is a great thing to work through with your coalition and folks who use data. Anyone can learn how to do this over time. I'm going to wrap up our work by talking about sustainability. And sustainability is probably the thing I think most about in quality improvement. You can do a lot of work, roll up your sleeves, get hard work done, your funding runs out in 2 years and boom, bust. We don't want boom-bust cycle to happen much like it does in the oil industry in our work. We want to sustain and hold the gains that we have. How do we do that? Well, that's a 2-hour webinar. I'm going to do it in a few slides, and hopefully you can start to think about some strategies of your own for sustaining improvement. First of all, plan for sustainability from the start. Someone asked a question about when to engage partners and stakeholders. You engage them at all points, and one of the ways that you can think about engaging and selecting partners is by thinking about what role do they play in sustaining the work you're doing. Is everybody at the table who needs to be in order to make this work? This includes your funders and identifying multiple funding partners in the very beginning of your work. Also, in order to sustain improvement, as I mentioned before, you need to build infrastructure. Having a governance structure that's aligned with your improvement process is critical. If you do not have the kind of structure you need to actually get work done, either with a board or work groups with rules, you will not be able to do this work. Sorry, but it can't be loosey-goosey, as one of my professors used to say. You have to have structure. Choose an accountable team to lead your coalition. Leadership is something we haven't talked a lot about, but it is a critical part of community health engagement to build a team that is accountable to the work you're doing. Accountability is actually a concept in QI that we don't talk a lot about because we're more about failing and learning from that than we are about accountability. In QI, we still need a team who is accountable to making the system work and to striving for improvement, not necessarily the results of your work. Finding that team of people who will own that usually means the leaders of your partners. Those folks who sign off, who are engaged, they may not come to every meeting, but they know they're on the hook for doing their part in this work, and they are accountable and believe in that. Aligning your resources with improvement work is critical. Often in our work in public health, we have ebbs and flows of funding, ebbs and flows of support, and in policy change. It's important to plan for that and to align the resources you have with the improvement work you're able to do at different times. Implement systems to support shared learning with your partnerships and with the teams that you have. Learning together is the critical ingredient to doing QI effectively. To sustain your improvement, you need to build a culture of adopting change and working toward change. If everybody believes that they should be part of a learning community and actively engage in it, then you have something that can live beyond the cycle of funding that can continue to go forward in the future. Second to last, review data continually to identify opportunities for action. I could repeat the word data, 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 and it would still be the same concept. Data matters so much to QI. It's just foundational. Working together as a group to continue to keep data in the forefront is incredibly important. Also, don't forget to develop your coalition's capacity for QI. You'll have new people come on board as you develop your collaborations, and you'll want to teach them the tools of the trade. Have them listen to this webinar, develop your own model for improvement story. You may also want to hire an improvement advisor or QI specialist whose job it is to orient new members to the QI process and to continue professional development toward this model. Remember that quality improvement is dynamic. I used to think that change was something that I had to be ready for, and I had to just know that everything was a certain way in my work. If something changed, I would have to react really strongly to it. It's much better to embrace how quickly things move in the environment that we work with in public health. Things change on a dime. Allegiances, policies, funding, all these things change. QI only works if your coalition embraces learning and change and continues to collaborate with one another in a context of a changing environment. Do not be afraid to change your aims based on your data and learning, and tackle new issues as you get more experience. As stuff comes up, you're going to be like, wow, I had no idea this was going to happen. This is hard. The hard stuff is where you learn. The hard stuff is where population change is possible. And that's the stuff that we don't get paid to do, but we want to do for the work that we do as public health professionals. So don't be afraid to tackle things that come up that may not be in the purview of your aim statement, but might be necessary or a new primary or secondary driver. And finally, diversify your coalition partners as you take on new challenges. This question was so important that it was asked before, and I've come back to it again, that as you build your partnership, you're going to need more people potentially to deal with new issues as the environment changes, as the needs change, and as your work continues. I didn't put this on the slide, but I did want to mention that sometimes there are partners that aren't needed anymore or are sabotagers. And there is a process for minimizing their involvement. Potentially, you can have folks who buy into an aim but then fall off the face of the earth and aren't inclusive. Those folks, as long as they're not getting in your way, it's incredibly important to acknowledge they exist and to try to re-engage them. It's the folks who are on board who actively disengage or sabotage your work that's the problem. This is where having a QI specialist or improvement advisor as an outside voice can be incredibly useful so that you do not have to take on these challenges. Difficult conversations are hard to have, but if a coalition partner is not pulling their weight, not doing the things that they promised to do, use collective speak and look at the data. Go back to your data, show the data, and then ask your partners, why isn't this working? Eventually it will come to light that some driver is not working and that partner is not doing what they need to. But again, it's about embracing failure. If they continue not to be successful, bring on another partner to do that work. So, to sum up, there are some key takeaways I wanted to be able to communicate today, and I know this is a very long webinar. If you've made it this far, I wish there was a prize I could give you, but I'm not allowed to do that. Building coalition infrastructure around QI as a concept and method is about shared learning in teams. If you develop an ambitious aim statement, which includes the for whom, how much, and by when components, you'll be better served in the work that you're doing. Again, learning from your data. Developing PDSA cycles from your driver diagram are essential, and you should start small and scale upward. Don't be afraid to work in many areas at once, but always remember to start small. Select a few specific measures that are tied to your drivers and report on them to the entire coalition. Again, 6 to 7 measures is the sweet spot. Do not go over 40. Because nobody wants that. And believe you me, the more data you have that isn't relevant, the more that will tie up precious time that you need to work on the actual drivers of change. Use the run chart tool to assess improvement and apply the rules 1 through 4 to know whether you've changed. Those rules are scientifically valid. You don't need fancy statistical software to know whether a change is improvement. And that's the magic of QI. Also, revise your aims when you are sustaining successes. Don't be afraid to change and adapt. QI is ever about adapting and changing as you change the landscape of your work. I'd like to end with this final thought for those of you who drive into Boston or used to drive into Boston while the big dig was going on. This is the only picture I could find of this, but I remember driving into the city and it said, Rome wasn't built in a day. If it were, we would have hired their contractor. Remember, change is so hard to do, but it's meant to accelerate your progress. QI is meant to accelerate your progress. If QI was around, the big dig probably would have been better. But again, lots of partners, lots of reasons why the big dig wasn't a QI project. QI is an excellent tool. Remember that it's only a tool, and it's one aspect of your toolbox. There's many things that we have in our public health toolbox that we can pull out at any one time. Be creative. So that's my shining face and my email address and phone number. Feel free to email me. I'd be happy to send out the driver diagram templates and the slides so that you can edit them. Feel free to use that. And after this webinar, there is a pop-up feedback survey, I believe, that comes up, Gina, for folks to take if you like to do that. We'd be very happy for the feedback. This is the second time I've done this webinar, and I would really love some constructive feedback from y'all. So with that, I'm going to open the floor for any additional questions. We do have about 10 minutes, but we'll close early if we don't have any questions.
Don't have a question, but I just have a comment. Throughout Karen's webinar, she did sort of nod to some of our past webinars that I think would be useful as you're thinking about the work that your coalition is doing and implementing some of these PDSAs. We do have a webinar that's recorded on our YouTube page that's called Using Data Effectively. And so when we're talking about how important data is in informing the work, we encourage you to take a look at the HRiA Institute YouTube page and take a look at that webinar along with another recording that we have called Identifying Multi-Sector Partners. So if you're just starting your process and you want to engage people from all different sectors and areas into the work that you're doing as you're starting your PDSA, that's also a great tool for you to use when you're thinking about your work. So I think if we don't have any questions, we're going to move into letting you know about some other work that we have going on. We have our 2 series coming up this month and next month. Starting, we have our Health Equity series in community building and our CHIP series, or our Community Health Improvement Planning Process. And we're very excited about these. We want everyone that's in coalition work to be able to take advantage of this great information that we have. Again, look for us on our social media, HRiA Institute, on our website. You can tweet us. We've been tweeting throughout this webinar, and we try to use our hashtag MA Coalitions all over the place so that you can find us and all the great information that we have. I want to thank Karen for doing such an amazing webinar, and thank you guys for hanging out with us for this hour and a half. We hope that you enjoy your lunch. Now it's that time, and we'll see you at our next presentation.